Welcome everybody to this Shockwave sponsored webinar from Johnson & Johnson MedTech. We're going to be talking about cracking the calcium code and understanding Shockwave IVL's mechanism of action across multiple calcium morphologies. I have an absolutely fantastic panel with me, Alok Finn from the University of Maryland and CVPath, Professor James Spratt, in his true holographic sense, will be doing a short video for us on the mechanism of action, and Jay Catry, who's not too far from me at New York Presbyterian at Cornell Medical Center, is going to be joining us as well. So to no further ado, the plan for today is going to be to go through some presentations, leave an opportunity at the end for both Q&A, which you can use the Q&A itself or the chat, that we can have a meaningful discussion and answer some of the questions that you may have. So Alok, let's take it away.
Fantastic, Ziad. Appreciate the introduction. All right, so we're going to present a little bit of a more basic view of how Shockwave works in terms of its mechanism of action than you normally get in terms of the imaging you're used to in the cath lab. We're going to present a little bit more basic, and this is really presented on behalf of Ziad and myself. Ziad was a co-contributor to this study we did, which was recently published in JACC Interventions. Here are my disclosures. So when I'm in the cath lab, I think I'm oftentimes thinking multiple things about calcified lesions. This is a 68-year-old female with multiple cardiac risk factors who presented with a STEMI and was referred for coronary revascularization. I think some of the questions I ask myself when I do these cases is, and I'm probably thinking from the more basic pathologic level, what are the morphology and extent of coronary calcium in the lesion, target lesion I'm thinking about intervening on? And based upon calcium presence and extent, which device should I choose to repair the lesion for stenting? What is my go-to device in which situation? How do I decide? Are there drawbacks or advantages of using one approach or another? And what are the effects of IVL on different calcium morphologies and extents? Some of the questions that we don't really have good answers for. All right, I'm going to review a little bit of coronary calcium background before I go into the study. Obviously, coronary artery disease and calcification are concomitant. Essentially, go together. And as you know, coronary calcium is a future predictor of coronary events. Coronary calcium correlates with the extent of CAD. And if you look at the prevalence of coronary calcium, it's prevalent in over 100% of people greater than 60 years of age. That's how common it is to see coronary calcium. In men dying of sudden coronary death, 46% on radiography have coronary artery calcium. Women generally lag behind in terms of the development of calcium, but they'll catch up soon after menopause. And there are several risk factors for coronary calcium, which I won't review in detail here. Calcification, two different types. This is a more basic knowledge of calcification. Medial calcification, as you know, mostly affects peripheral arteries of the lower extremities, really encompasses the media. That's why it's called medial calcification, and is regularly observed in subjects with peripheral vascular disease. And progression of medial calcification associated with renal failure, hypercalcemia, hyperphosphatemia, things that we think about in terms of renal failure itself. Intimal calcification is the dominant type of calcification seen in coronary arteries and associated with atherosclerosis and its risk factors. And as you see here in this slide, I've gone over in detail the morphologies of calcium we encounter in coronary artery disease. You can see here, as we start from early lesions and go to late stage lesions, the calcium starts to increase. In terms of early lesions like pathologic intimal thickening or fibroatheroma, there's punctate calcification or more fragmented calcification. Even thin cap fibroatheromas, which are predecessor to ruptured plaques, have more fragmented and scattered calcium. It's really the lesions that are heavily calcified are those that have sheet calcium. That is calcium that is described morphologically as looking as a sheet surrounding the artery in terms of in the intima itself. And that really encompasses lesions such as fibrocalcific plaques, healed ruptures, and even CTOs can have calcium. Generally, plaque erosions are calcium-free, have very little calcium. So it's important to understand the different types of calcium and morphologies you'll encounter in the cath lab. This is a slide just to show you the technique that we use in some of our studies. Obviously, plaque progression and calcification, I said, go hand in hand, but you can see here, I'm showing you the histology on the upper panel and the micro CT. So not a CT, but literally a micro CT, super high resolution CT that's really not clinically available. The micro CT is an extremely important element in terms of detecting calcium because it's so sensitive to detecting different morphologies of calcium, much more than a clinical CT would be. And you can see here I've matched histology to actual micro CT, and you can see, for instance, on uh, the fibroatheroma on the right-hand side, you can see the extent of calcification is shown beautifully in the micro CT, and it matches exactly where the histology is shown. Same with the sheet calcification in the lower panel. You can see how much sheet calcification there is there, and showing beautifully on micro CT how much the exact morphology of the sheet calcium itself. Very useful technique. Calcium obviously is highly encountered in sudden coronary death. This is a paper we recently published where we graded calcium extent in sudden coronary death victims and those who didn't die, who died of a non-CAD death. As you can expect, as you get into the 60s, 70s, and 80s, the extent of calcium was severe in a fair number of cases. And by the 80s, it encompassed over 65% of those patients had severe calcification. So just to show you, people with coronary artery disease who age get a lot of calcium in their coronary arteries. So what was the background and objective of our study? Well, this study looked at calcified coronary plaques, and we know they pose significant challenges to percutaneous coronary intervention due to resistance to balloon dilatation and risk of stent underexpansion. We all know that. Traditional devices such as cutting balloons, ultra-high pressure balloons are commonly used to modify calcified plaques, but there are few studies directly comparing their effects with those of intravascular lithotripsy, which uses acoustic waves to safely and effectively modify calcified plaques. So the objective of the study was to address the lack of comparison of these different techniques in modifying calcium and comparing the efficacy and safety of IVL, cutting balloon, ultra-high pressure balloon for the treatment of severely calcified lesions. So the materials and methods were sort of special in this study. We obviously used cadaver hearts. They were fresh and they were thawed. And then we basically did a micro CT on the arteries themselves, looked at the extent of calcium, and then picked out certain lesions based upon calcium criteria. And those criteria were stenosis greater than 50% on angiography and OCT, and a minimum length of 15 millimeters, and calcified plaques detectable on both OCT and angiography. Those are the criteria to pick out the lesions themselves. Then we randomized the lesions among three different techniques. One was obviously IVL, Shockwave, Wolverine by Boston Scientific, and OPN. And then following the lesion identification, we basically conducted a pre-micro CT and then a post-micro CT after the lesion was treated to see what was the extent of fracture with each different type of device. We looked at two things as endpoints: calcium fracture, usually using micro CT and histology, and then medial injury as well, using mainly histology. We also used OCT in this study, and every plaque was co-registered with the corresponding micro CT, OCT, and histology. This is just a little bit of methodology for you. Here we're using multiple methodologies: angiography, Faxitron X-ray. You can see here on the lower panel, in the middle panel, you can see the micro CT where we're showing you pre and post fracture corresponding with histology after we had done these interventions. And then, of course, medial injury was mainly detected by histology. And I can show you an example of a tear in the media shown in the lower right-hand portion. So these were the lesions that were assigned randomly to each different treatment arm. IVL, 5 lesions, cutting balloon, 6 lesions, ultra-high pressure balloon, 6 lesions. You can see here the calcium arc, the length, the volume index, and the calcium thickness did not differ by groups. So this is a way to equalize and equalize the playing field. And you can see the treatment protocol was per IFU. Shockwave, 120 pulses delivered at 4 ATM. The balloon was sized 1:1. The cutting balloon was for the COPS trial, average inflation pressure of 18 ATM. Balloon size according to the IFU. An ultra pressure balloon, again, ISAR calc, average inflation pressure of 34 ATM. Balloon downsize 0.5 millimeter to the reference vessel diameter. Now, this is an important slide. Here we're showing the frequency of fractures in medial injury by lesion as detected by micro CT and histology. So here you see in gray the fracture incidence per device. You can see IVL was successful in fracturing 80% of lesions. The medial injury was very rare, found in 1 out of 5 lesions treated. You can see that cutting balloon was also successful to a little bit lesser extent than Shockwave at fracturing calcium. 66.7% of lesions were fractured. And you can see those fractures also went along with medial injury, and in some cases, just medial injury itself, as you could guess here by looking at the graph. And ultra-pressure balloon was the least successful in inducing calcium fracture, and it also induced the most medial injury. All lesions treated with ultra-pressure balloon showed evidence of medial injury. Medial injury was significantly different between IVL and cutting balloon and IVL and ultra-high pressure balloon. Here's an example of what I'm talking about here as an example of circumferential calcium. You can see IVL clearly induces fractures from the pre on the left to the post where the little arrow is showing you clearly on the OCT on the upper panel and the micro CT on the lower panel, clearly evidence of a nice fracture within an area of sheet calcium. Cutting balloon, here you can see evidence of fractures that were induced by cutting balloon, and the same was shown down here by ultra pressure balloon in this one section. And the corresponding histology is shown on the right-hand side. Now, we wanted to look more at clinically relevant information. Therefore, we chose a section-based analysis. Each section was analyzed and graded according to the extent of calcium. When I say extent of calcium, I mean, was the calcium arc greater than or equal to 180, or was it eccentric calcium that is less than 180? And how did the devices do in terms of concentric calcium and eccentric calcium? You can see here in terms of concentric calcium, fracture was seen in 100% of lesions or sections treated with IVL. There was no evidence of fracture with medial injury or non-fracture. In the cutting balloon, there was 16.7% of lesions had evidence of fracture without medial injury. 33% of fractures, 33% of cases had fracture with medial injury, and 50% of cases had non-fracture. Ultra-pressure balloon, same, not very successful. 20% of lesions had evidence of calcium fracture without medial injury. 80% of lesions had evidence of fracture with medial injury, and there was no non-fracture. You can see here in the eccentric calcium, none of the devices was as successful. IVL fractured 57.1% of lesions without medial injury, whereas there was no evidence of fracture with medial injury, but 42.9 had non-fracture eccentric lesions. Cutting balloon was even less successful. 11.1% had fracture without medial injury. 33% had fracture with medial injury, and 55% of lesions had non-fracture. And ultra-pressure balloon did not perform well, as you can see, in eccentric calcification, had no fractures whatsoever, and had only had non-fractures, essentially. Let's see if we can, okay. And this is just representative examples of those histology on the micro CT and OCT on the left, and the histology on the right, showing you, for instance, for ultra pressure balloon, you can see there was really not much evidence of fracture, but there was a large medial tear on the histology in the lower right box. As you can see, the device impact on calcium arc less than 180. Same thing, cutting balloon really did not have a good effect, but did have evidence of medial injury. Let's see. Okay, so medial injury obviously was a big topic of this paper. What does it mean? Well, medial injury is a component of the Schwartz injury score. We use it as an essential marker of the chances of restenosis or neointimal formation. The more the injury score, the more the neointima will form. And you can see, I don't know how well you can see this, but in Schwartz score 2 and 3, medial injury is an essential component of higher injury scores. And you can see on the right-hand graph that there is a direct correlation between the degree of medial injury as a score and the neonatal thickness. So I think medial injury would not be described as a desirable effect in terms of coronary intervention. Okay, and this is data from human pathology, older papers, basically just showing you from old human studies that where medial injury is fracture is present, there is significantly more neonatal thickness in human cases, and there's significantly more chance of restenosis. I think this even applies in the era of drug-eluting stents. Now, the last part of this talk is about calcified nodule or nodular calcification. We talked a lot about types of calcification and morphologies. Well, we've so far really shown you data with sheet calcification. These are all cases where there was large, extensive sheet calcification. But calcified nodules and nodular calcification obviously are also encountered in coronary arteries. Now, just a little bit of a brief, nodular calcification, of course, is a morphology of calcium seen in coronary arteries where there are nodules of calcium within the intima, but there's an intact fibrous cap. Whereas calcified nodule is a specific entity, some people refer to as eruptive calcified nodule, where the nodules of calcium essentially erupt into the lumen, causing a fibrin-rich thrombus to form. These are usually cases that present with ACS. Now, it's not clear, I don't think we have good data in humans about how does IVL affect nodular calcification. And you can see here I've shown you micro CT pre, 10 pulses, and then 20 pulses in. And I want to show you more clearly on the cross sections, what does IVL do? You can see pre, there's lots of nodules in this lesion cross section. You can see the IVL essentially breaks those nodules into smaller and smaller pieces as you deliver more and more pulses to it. So IVL has an effect, as I've shown you previously, on sheet calcification, but also in this brief work, and this will be published later, on nodular calcification as well. So in conclusion, coronary calcium, I think, as I've shown you, is concomitant with the progression of CAD. Sheet and nodular calcification are the predominant morphologies essentially we encounter in the cath lab. IVL effectively modifies calcified coronary plaques, achieving calcium fracture across a range of calcifications while minimizing medial injury. And medial injury, as I showed you, is linked to increased risk of restenosis and other events. Compared to cutting balloon and ultra high pressure balloon, IVL consistently induced fractures with fewer complications, even in lesions with smaller calcification arcs, although it was less successful in those with eccentric calcification. IVL effectively treated nodular calcification, but its effects really need further study. I think it represents a safe and effective option for calcium modification, offering advantages in the treatment of calcified coronary lesions based upon its unique mechanisms of action. So with that, thank you for your attention.
Thank you so much, Alok. So I think what we'll do is have one burning question for sort of each of these. And I think Jai and I have the same question. And that is, in the era of drug-eluting stents, do you think medial injury has an impact on the burden of neointimal hyperplasia and restenosis?
I do, yet I still think we don't really know. The problem is when we see a restenosis case, we've put a stent in, we really don't know whether there was medial injury. So we don't know the factors that went into causing that restenosis. So I think we tend to underestimate in the clinic that technique and not injuring the vessel too exuberant really does matter in terms of outcomes. We just don't have the technologies to tell us how much medial injury we actually did when we implant the stent. But it's certainly easy to do it. As you see with the ultra high pressure balloon, there's a lot of medial injury induced by going to 34 atmospheres.
And one of the
I guess that's the other big question. How do you know in the cath lab when you've induced severe medial injury? How can you tell?
Jai, I think it's very hard to know using current imaging techniques. I mean, I think they don't really get deep enough into the wall to identify the media. You know, when there's a large intimal plaque, Jai, and most of these cases have huge intimal plaque, you can't really see behind it. So I think we're limited by our current imaging technologies in terms of what kind of damage we're doing. But when we go to ultra high pressure, my personal feeling is those balloons probably have a preference to expand on the normal side of not the normal, but the non-calcified side of the vessel, inducing medial injury on that side away from the calcified plaque.
And I do think the presence of angiographic presence of contrast in the media is definitely an obvious medial dissection.
Yes.
But it's an important question, and that is we have pathological data to support very clearly that the amount of medial damage impacts restenosis rates. In fact, in the periphery, when they were doing directional atherectomy, penetration of the media with directional atherectomy has a nearly 100% restenosis rate, which is just testament to the very vigorous and robust response from the adventitia, cellular response that can lead to neointima.
Yeah, you get a very vigorous response. You can see in the animal data then when you see a lot of medial injury, you get exuberant neointimal proliferation.
Well, on that note, I think what we'll move on and that is really talking about the mechanism of action. I think this dovetails beautifully from what you just spoke about. And we're going to hear James Spratt talk to us about IVL's mechanism of action.
My name is James Spratt. I'm a professor of cardiology at St. George's Hospital in London. And I'm going to talk to you today about the mechanism of action of IVL and why that's important to your clinical practice. So let's ask ourselves, what are the ideal properties of a calcium modification device? Remember that we want to disrupt vascular calcium, but we don't want to injure the vessel. So we're going to look at that. We want the device to be target oriented. In other words, the force is always oriented towards the target. So in contrast to balloon angioplasty, we want it to be focused on the target and only focused on the target. We want it therefore to be target specific. And we want the vessel, the risk to the vessel to be low, that the force applied is safe. So we're going to divide this into 3 key points for you to remember and to apply in your clinical practice. Key point number 1 is that shockwaves only generate disruptive forces when they encounter a large change in acoustic impedance. So if the shockwave is traveling from a fluid-filled balloon across soft tissue, there is no disruptive force generated. If by contrast it encounters a zone of high acoustic impedance, then the energy is transferred at that juncture. So you can see here going from the balloon to calcium, there's a transfer of energy. There's 80% is transferred to the calcium, approximately 20% is reflected, and that's what results in the generation of the disruptive forces that fracture the calcium. And if we see that in clinical practice, here you see eccentric calcium on the left, normal vascular tissue, so in other words, low acoustic impedance. On the right, high acoustic impedance. And if we zone in there, we can see that the shockwaves will pass harmlessly through the normal vessel. But by contrast, if we look at the zones of high acoustic impedance, you'll see that there is a transfer of force and therefore a disruption of calcium. And this also applies, of course, if the calcium is lying deep in the vessel. So there's a zone of low acoustic impedance here with the fibrous tissue and a zone of high acoustic impedance distal to that. So again, passes through the fibrous tissue and fractures the calcium deep to that fibrous tissue. Why does this matter? Well, it translates to a higher efficacy and less injury. And that was seen in the cadaveric study that you're also going to be hearing about in this webinar, where there's a higher instance of fracture from IVL when compared, at least numerically, with cutting balloon and ultra high pressure balloon. But even more importantly, there was a much lower instance of medial injury, and that's the yellow bar you see. So very low instance of medial disruption when compared with equivalent treatment with cutting balloon and ultra high pressure balloon. And we can look at that here in a zone of eccentric calcium, and this selectivity matters most in eccentric calcium, because remember, if you have concentric calcium, there's literally nowhere else for the force to go. So you can apply a lot of force and the vessel is in some way protected from that force. By contrast, if the morphology is eccentric, then the normal tissue can be exposed to extra forces and that can lead to disruption. So here on the top, it's IVL, micro-CT, bottom OPN. And you can see post-treatment, there's a fracture in both, but critically, there's disruption in the medial layer in OPN at the bottom, and the normal vascular tissue is normal at the top. And we can look at that in some more detail. So zooming in at the fractures, you can see there's a disruptive fracture there and eccentric calcium in both the modalities here. But if we look at the normal vascular tissue, there's no disruption on the left with IVL, and there is disruption with OPN. And this MOA is critical because it explains the safety profile, and the safety profile we've seen across multiple studies to this date. You've got disrupt CAD on the left, which is this incredible safety profile of no dissection, no perforation, and no acute vessel closure. But even more importantly, this extends beyond this rather controlled environment of IDE studies into real-world registries, and we still see this in very impressive safety profile. So the second key point, the acoustic pressure waveform has been modulated to maximize safety with efficacy. And this shockwave, this medical shockwave, is a high energy acoustic pulse and has this very steep, high pressure pulse compression phase. And you can see this is up to 100 megapascals, but also critically this negative pressure or tensile phase. This is actually the extracorporeal lithotripsy waveform that we see here. And in that case, the shockwave waveform has been significantly modified. And that's because, first of all, it's intravascular, so therefore the pressure waveform required to disrupt the calcium is much, much lower because it's much, much closer. But even more importantly than that, there's modification of this tensile waveform, or this negative pressure waveform, to reduce this. As you can see here, there's this high amplitude, short duration, positive peak pressure, and that maximizes compressive stress for calcium modification. But the safety is determined on the low amplitude negative pressure with a longer wavelength that minimizes soft tissue damage due to the tensile stresses. So what is the final key point? The final key point is that it's effective across the duration of the balloon. This high sonic output across the length of the balloon is both circumferential and consistent. So if we look at it from a longitudinal perspective, and compared within a vessel architecture, you can see these are 3 or 4 millimeter lengths extending deep to the balloon. These dots represent the pressure, peak pressure that can be generated by the balloon. And you can see that they extend in a circumferential direction. There is a peak effect perpendicular to the emitters, but there's actually a summative effect in the middle. So there's no black spot, if you like, or no absence of effect across the length of the balloon. So yes, the effect is highest perpendicular to the emitters, but there's a really very little loss of effect in the middle of the balloon, and the force extends deep to the balloon, but also in a transverse longitudinal direction beyond the balloon. Critically, you can see here, as the further away you get from the balloon, the less effect it has, and that's what we refer to as the field effect. If we look at it in a radial perspective, you can see that the force is completely circumferential, and this is a time generated waveform from the point that the shock waves leave the emitter. You can see they extend in a completely circumferential diameter, and this is a very important point because there was some suggestion that there might be this blind spot on one side of the emitter, the other side of the emitter, and that's really not the case. It extends completely circumferentially. So therefore, in summary, I would say that shockwaves only generate disruptive forces when they encounter a large change in acoustic impedance, and that's what makes them so effective, but also so safe when encountering vascular calcium. And this acoustic waveform didn't happen by chance. It's been modulated to maximize safety with efficacy. And finally, due to these latest ex vivo studies, we can say definitively that the high sonic output extends along the length of the balloon, both in a circumferential and a consistent fashion. Thanks for your attention.
Great session. I think there was some really new insights from mechanism action. Any comments from you guys?
I think that this whole idea of the
Question.
shock waves being circumferential is really what's fascinating, because that's an area that there was a lot of discussion about whether this was truly the case or not, or whether the energy was just 180 degrees opposed from the emitters.
Yeah, I think the explanation is really nice, and it's borne out, of course, by the study we conducted. And obviously, the clinical data looks good, but the study really does belie some of the mechanistic information he's mentioning. So that's a nice way to put it all together.
What better way to put it all together than in some cases? Let's see it in action.
There's a chat question too at some point, Ziad. Just check it.
Okay.
Well, this the chat question actually gets into what these cases are all about. So I'll be the provocateur and have you guys chime in on what you think you would do with these cases, because I struggled with both of them. The first case is an 80-year-old male presenting with declining functional status, primarily complaining of exertional dyspnea with daily activity. Has the usual slew of comorbidities: hypertension, hyperlipidemia, peripheral arterial disease, he's got carotid disease, COPD, former smoker, and also has pretty severe renal insufficiency. His GFR is only 30.
Hmm.
His referring cardiologist had already done a nuclear stress test on him, which showed predominantly fixed defects of the inferior wall as well as the intra-apical wall, with a depressed EF around 33% with TID. And he was sent for a left heart catheterization, which shows really pretty heavily calcified and severely stenosed circumflex disease in the setting of both an LAD as well as RCA CTO. So this is his coronary angiogram. So really what I wanted to highlight here is that there's a substantial amount of calcium that you can see on the right panel, even without X-ray dye. So you can see where the MAC is around the mitral valve, and you can follow above the MAC. You can see all the calcium in the circumflex and down the LAD. So a heavily calcified coronary tree with a last remaining conduit with CTOs of the LAD and RCA with depressed EF. And the questions really for the panel are, how would you approach this? And so we'll go to the next slide, please. This is sort of like kind of funny now with all the data you all have presented, but would you go with a high pressure non-compliant balloon angioplasty? Would you go with IVL? Would you go with cutting balloon angioplasty? Would you do rotational atherectomy, or would you do all the above?
When it goes the audio, you mean it. Go ahead.
Well, I think there's a couple of very key features to this, right? One is it's your last remaining vessel. So he's not going to be able to tolerate risk. So if you end up with a bad dissection, or if you end up with slow flow using atherectomy, I think that's where your potential problems are going to come. So one of the questions that came up in the chat is, how do you know when to opt for shockwave orbital atherectomy or rotational atherectomy? Somebody asked me this, very recently, because I think the first thing we should do is understand and admit that they all work, right? Roto works, orbital works, cutting balloons work. So how do you decide when everything works? And so the analogy that I have is, I recently had a hornet's nest at my house, and I had three options. Okay, I could spray it, I could put this powder on it, or I could use gasoline. Apparently gasoline is highly effective for this. So you know what I asked the guy? I said, which one's the safest? And he said to me, use the powder. And I said, let's go with that one. So if you analogize that to real life and go back here, I think what's unparalleled about IVL, and was brought up in James's slide as well, the numbers that for complications for IVL are so low, they compare to regular plain old balloon angioplasty. So for me, the vote is always to take the safest device, and in this case, my vote would be for IVL.
Yeah, I am in full agreement with that. I mean, my experience is that if I can get the IVL catheter across, and I mean, Jai, that's the issue for me, is that if we can get it across, I will certainly use IVL first, because I just think it's the safest. But if I can't, then I might go rotational. But obviously, this guy is low EF. might not tolerate rotational well. Like Ziad said, complication with rotational, you might end up in trouble. He may end up in trouble.
Yeah, can you guys go back? Yeah, let's go to this slide. So honestly, my whole idea here was just in line with what you said, that atherectomy may or may not be terribly well tolerated, and this is highlighted by how incredibly angulated circumflex coronary arteries can be. So we evaluate them in a two-dimensional image on the angiogram, but they're quite three-dimensional. And you can see on this still frame I show of the IVUS separating from the workhorse wire, how incredibly angulated the ostium of the circumflex was. So the thought of taking an atherectomy burr through that just was not particularly appetizing. I wasn't really too sure how well he'd tolerate that with his low EF, and this being his last remaining conduit, I certainly didn't want to have some terrible injury here. So ultimately, we were able to get a microcatheter and a wiggle wire down and did some intravascular imaging, and we can go to the next slide. And what I elected to do was IVL, 2.5 by 12 IVL, based on what the IVUS in the right lower panel indicate. And based on what I was seeing on the rotational angio, so I go up on the IVL balloon and I rotate the C-arm around at least 60 to 90 degrees just to see if the constraint in the balloon has been resolved. And once I'm happy with the resolution of constraint, I feel pretty good about just go ahead and putting the stent in. So that's the stent going in on the right panel. And then if we go to the next slide, we got a good angiographic result within the stented segment, but as things go, we lost the continuation of the AV groove circumflex. So the stent went in, was expanded, was post-dilated appropriately, lost the AV groove continuation. Patient was entirely asymptomatic without any EKG changes. I thought we got a reasonable MSA, which you see in the right lower panel. And that was sort of how we concluded this case. It was sort of less is more in this case, where we didn't have a lot of reserve to work with. I don't know if you guys have any comments on that.
I think
Yeah, I mean, I think sometimes when you lose these branches, when you have last remaining conduits, the patients really tank. But fortunately, that wasn't the case here. But I think an MSA of 5.2, our cutoff is generally around 5 for IVUS with a good long-term clinical outcome. And like you said, the enemy here would be to try to get great from good, right? And then we'd be end up in bigger trouble. So I agree with you completely that this is easily managed with Shockwave IVL. And how long did the case take you?
Not very long. We're done within less than an hour.
Yeah.
I think that's one of the other advantages. You don't have to prolong the case in these sick patients. Last remaining vessel, the case is faster. You don't have to bring in gas tanks. There's none of that sort of stuff. So the case actually has a momentum to it. And the momentum, I think, is very, very important in terms of minimizing complications.
Or not. And this is pretty interesting to see that that's not the case. That this seems to be a circumferential effect.
And you're doing this for
Yes.
relief of angina. You're not doing this for anything else. So to me, as long as the guy can do more activity, you've done exactly what you should have done, which is just improve his functional status.
Agreed. So in the interest of time, I'll move on to the next case. So this is sort of a similar story. 73-year-old male who presents with declining exercise tolerance. His EF is preserved. He's got moderate aortic stenosis. The usual comorbidities: diabetic, hypertensive, hyperlipidemia. His referring cardiologist also did a SPECT, which showed primarily anterior wall ischemia. And he was also sent, interestingly, for a coronary CT angiogram, which showed heavily calcified and severely stenosed proximal LAD and moderately diseased, diffusely diseased dominant left circumflex. So if we go to the next slide, I'll show you these are two stills of his coronary tree. So left dominant circumflex and proximal LAD disease that's quite angulated. And so we'll go to the same questions. How would you approach this? What would be the best way prior to deploying a DES? High pressure NC balloon, IVL, cutting balloon angioplasty, rotational atherectomy, or all of the above?
I'd be nervous to try rotational there because of the angulation of the LAD. I don't like it. But at the same time, a little hesitant because there's an angulation there And I don't know if IVL will cross that so easily. So I'm
Yeah.
a little bit concerned about how you're going to do the case. You'll need a lot of, guideline or backup, I think, for this. But if you can push an IVL balloon, I think it's the first choice in this complicated case.
So let me be the first to talk about Aero. I don't know if either of you have the new Aero device.
I just used one today.
It is a complete game changer for me. I mean, this, lack of pushability, not being able to push IVL in tortuous spaces. I mean, I have pushed this thing and I literally cannot believe what it can do. I mean, it carries, to me, it tracks slightly better than a non-compliant balloon. I mean, it's
I would concur.
very
Wow.
flexible, very lubricious. I mean, I've been very impressed with it so far. I think it's a complete paradigm shift in Shockwave's
I would
catheter
concur.
design.
I would concur. I especially had trouble with the 3.5, and I used a 3.5 on purpose today and had no issues at all going through a very, very tight lesion. So I think if I had had that today, that's what I would have done, but I did not. So the primary approach, as Alok had mentioned, was to try to avoid rotational atherectomy because of that angulated lesion. But we had trouble getting even a microcatheter to cross this lesion, let alone a balloon. So we ended up just sort of nosing in the microcatheter as deep as we could and airmailed a rotowire into the LED, and ultimately did rotational atherectomy using a 125 burr. It took a full minute of atherectomy with just leaning on the lesion before we were able to finally create a path. But ultimately, we did get the atherectomy done, and then we're able to swap out for a wiggle wire again over a microcatheter. We go to the next slide. So the next question is like, what do you do after you've done all this? Do you IVL at this point, or can you just NC this and be done? This is the distal landing zone. And the next slide is
I would
the
IVL
area.
it.
This is where
IVL.
we did the rotational atherectomy, and you can see all the reverb where the
Mm.
wire bias is. I was curious what you guys think with this. Is this good enough?
I would IVL.
Yeah, I think the question is just what we go back to is if you do a high pressure post dilation here, you have a pretty significant risk of dissection. And this is very eccentric calcium. So basically, based on what, Alokanized data, this is the perfect place to do this because you have a nidus for dissection on the opposite side and you have wonderful catheter bias. So basically your IVL balloon is going to hug right into this calcium and potentially, I would say, fracture it even further.
It's
Yeah.
going to make it
And
maybe
what's
easier.
your opinion on that reverb in the far field? What do you think about that? Does that mean anything?
So it does. In short, it means you have very likely fractured the calcium. So reverberation is basically the penetration of sound into the back wall and the sound is bouncing behind it. We used to think it would be related to the thinness or thickness of calcium. We realized that that is actually not the case. So a perfect example of this, if you have 360 degrees of calcium, you should have no reverberation. If you have 359 degrees, and the sound has a space to penetrate, because it's a specular reflection, it bounces behind the calcium all the way around and will create a reverberation for you. So the fact that you have a reverberation here is highly suggestive that you have calcium fracture that you might not be able to visualize.
Yeah. And that's really where I struggled. Like, is this good enough or am I done? So that's the proximal landing zone. What do you do here? Do you need an IVL here? Can you just use your NC balloon to check and be done with it?
I mean, I think you have a big lumen area here, so I don't think this, really needs modification up here because you have such a big lumen area. And
But
so,
the angulation on that lesion is still there. I don't like that angle. I think it'll be easier if you IVL it, my personal feeling, but maybe make the procedure easier.
Yeah. Yeah.
okay.
And that's sort of the debate. So what I did here is I just took an NC balloon,
Okay.
2.5 at 30 NC, and I did a rotational angio again with a balloon inflated. Didn't see a lot of constraint in the balloon, and then went ahead and deployed my stents based on what that NC's behavior was. And we can go to the next slide. And this is what we got. So not quite 5, definitely eccentric expansion. And really, there's no way to go back and do a comparison here. But obviously, at the end of the day, you wonder if IVL had been done, whether this would have given you a larger MSA or not, but who knows?
Yeah, I gotta say, Jay, if I had this, I'd be having a little bit of IVL regret
Yeah.
because,
Yeah.
obviously there's an angiographic stenosis. It's the eccentric calcium that's holding it, and actually, IVL is the only modality of all of the modalities which has evidence to support its utility and efficacy in eccentric calcification. And that goes back to the title of this talk, is that IVL works in a range of morphologies. And then if we tie that to really James's talk, the fact is IVL doesn't know whether the calcium's eccentric or concentric. It doesn't care. It just delivers the energy into the wall. Where there's low impedance, it basically disappears, like hitting a pillow with a hammer. And where there's high impedance, it's going to create fracture. And so I think in this situation, as also was shown in the beautiful example that Alok showed in the calcified nodules, you're changing the compliance, because if you have one break in your windshield versus 100 breaks in your windshield, it will definitely change the compliance. This is all theory, but I think, at least from my point of view, you had little downside if you could deliver the IVL balloon to try and create some more fractures. But, we don't know whether it could have improved it. What we do know, I think, is from Bali, which was the recent randomized controlled trial, you do end up with more calcium fractures with IVL than you do with a balloon-based therapy. And if you believe that those fractures actually impact your stent expansion, which theoretically they should, then it makes sense that you should end up with a larger minimal stent area. And of course, the minimal stent area ultimately drives the outcome of PCI.
And what drawback is there, Ziad? I don't think there's much drawback to using an IVL in this. I mean, there's the expense, obviously, but that's the one thing that I would think about.
Yeah, but the expense really pales in comparison to the expense of a target vessel failure, right?
I agree.
They're not even, and
the time and everything else that's needed to really, if you have to post-dilate the stent and try to get up to high pressure, I just don't like that idea. If you can,
I mean, I guess one other approach that we didn't discuss, but has its own risk to it, you created quite a gutter and you had a lot of wire bias. Would you consider going back with a larger burr because you only used a 125? That would be another possibility. But again, given I think the eccentricity of this thing and the tortuosity, I mean, that's the advantage of a balloon-based strategy, in my opinion.
Yeah, I mean, this gets back to my original question to both of you: is when you're in the cath lab, how do you use intravascular imaging to assess whether or not your lesion's appropriately modified or not, and when you can move on? That's the thing that we struggle with.
That's I mean, honestly, that's basically a plug for Alok and I. So Alok and I spent a wonderful week of summer basically doing a psychopathological study as well as a pathology study. So Alok, you want to tell them what we did this summer?
well, we've got two studies. They're not all be presented at TCT, but one was Ziad really came up with this one. We're looking at the relationship of IVUS, OCT to fracture. Which is better? Are they the same? How good are they each at detecting fracture? And that goes back to your case, Jai. Obviously, we were looking at the reverberations. We showed in this previous paper I just presented that we showed that actually OCT probably missed about more than 50% of fractures. It was not, fractures were present, but they weren't distinguishable on OCT. So I think imaging has its limitations. Which modality is better will be answered by this specific study we're doing. But the other study we're doing also is dose dependence of IVL. How much dose do you need to fracture what type of lesion? If it's an eccentric lesion or concentric lesion, do you need the same dose? How many pulses do you need to create fractures? So we did this massive study where we basically delivered 10 pulses, micro CT, 10 pulses micro CT, 10 pulses to look and see in different morphologies of calcium and extents what type of pulse frequency or dose rate do you need to create fractures. Ed, you want to add something to that?
Yeah, I mean, we really designed these two studies to be clinically relevant because you asked a very clinically relevant question. Hey, Z, how many, on intravascular imaging, how do I know when I'm done? Yeah. And, before Alok and I presented the data at PCR, and I think 2 years ago, nobody realized that OCT missed fractures. Everybody thought it was the gold standard. In fact, if you remember and go back to Disrupt CAD3, there was a finding in Disrupt CAD3 that the patients who didn't have fracture had the same minimal stent area as those who did have fracture. And mechanistically, that was simply impossible for me to understand. If the thing on the box, you know, it does what it says on the box and it's supposed to break calcium, then how, if it doesn't break calcium, do you get the same MSA? And so what ends up happening, at least for OCT, is basically, if you think of this like a crystal, okay? And you get a crack in the crystal and you shine a light through it, unless the light goes through the crack and creates a refraction of that light, you won't see it. And so if you think of this, it's almost like an ice cube or a crystal. You packed it together, the light has no refraction, you won't see it. And so we missed 50% of fractures by OCT. And so as a result, we actually realized that the balloon was a better marker of whether you're prepped, like you quite astutely and eloquently do, and look around in multiple views. Now, one unanswered question is, does IVUS miss the same amount, more or less? Nobody knows. And of course, worldwide, IVUS is a much more commonly used method for OCT than OCT for calcification. We're going to be able to look at the predictors, whether reverberation matters, whether you can actually see the fractures, and whether or not there is a difference in the utility of being able to identify fractures by OCT and IVUS.
Great. It's going to be a great study, I think, once we get the data.
So we're at the just past the top of the hour, so I don't see any more sort of burning questions in the chat. If there are any, we'll stay open for the last couple of minutes and ask those questions. In the meantime, I'd like to thank all the participants for joining us. We know it's a Monday night. To have 100 of you here is actually very, very meaningful. What we'll do is we'll save IVL and nodular calcification for a future date because we'd like to give you your time back. And any parting words, Alok, Jai?
Fantastic seminar. I think we all learned a lot, and it was well put together. If I don't say so much.
Really enjoyed it. Learned a lot. Thought-provoking.
Exactly.
Okay, wonderful. On that note, thank you all for joining us on this Johnson & Johnson MedTech sponsored Shockwave Medical Symposium. We'll see you at the next one. Now we have to have a next one because I never got to present my stuff to you. But we'll have a deep dive on nodular calcification. We'll see you all at TCT. If we can just go to here, I'll do that and show you the last slides because we want to make sure that you all get that opportunity. And so just remember the important safety instructions by Shockwave Medical, and then of course join us at TCT. There's a wave after wave of innovation. Thanks very much everyone for joining us, and we'll see you next time.
Thanks, guys.
Thank you.